Welcome to this educational activity where Dr. Jonathan Silverberg from Northwestern University Feinberg School of Medicine discusses the diagnosis and treatment of adult patients with atopic dermatitis. The following audio is part of a certified educational activity titled A Patient-Centered Approach to the Diagnosis and Treatment of Atopic Dermatitis in Adults, an Expert's Story. Access the entire activity and complete the post-test at www.peerview.com/APZ. Downloadable slides and practice aids are also available.
Today I want to tell you about the journey of a patient in my care and her experiences with atopic dermatitis. Her name is Claire. She's a 23-year-old African-American woman who's pursuing a career in marketing and is working at her first job out of college. Claire has a history of atopic dermatitis really since early childhood. It was particularly severe for many years, but remitted during adolescence between the ages of about 15 and 18 years. It then recurred with a vengeance at age 18 with full body itch, redness, scaliness, etc. And she's really been unable to sleep very much, has missed many days of work, and when she was at work has had difficulty concentrating because of fatigue, daytime sleepiness, and has been making a lot of mistakes in the workplace. Claire's also had trouble in warmer weather because she didn't want to wear any clothing that was too revealing and wanted to be covered up as much as possible. She also couldn't wear any clothing that was too tight or would cause friction. She didn't want to go out with her friends and socialize because she was embarrassed by the rash. And that all led to a feeling of isolation and being depressed and down all the time. She's now experiencing sexual dysfunction secondary to the atopic dermatitis, which, combined with the self-consciousness about her appearance, has really further contributed to her sense of isolation and depression. Claire was seen by multiple doctors, including primary care physicians and dermatologists, who all told her that it was in her head and that she needed to see a psychiatrist for psychogenic itch. Eventually, Claire was referred to me, and when she came in, I looked at her and I was kind of flabbergasted. I said, you know, not only is it not in your head, but you're covered from head to toe with atopic dermatitis. She was erythrodermic, maybe 0.1% of her body surface area that was not covered with lesions. And there really wasn't any areas of normal skin. In terms of her past medical history, she has a history of moderate to severe asthma since childhood, and even now continues to have several flares a year. Has really ongoing seasonal allergies that tend to flare in the spring, is obese, and recently was diagnosed with high blood pressure that is being managed by diet and lifestyle modification. But she is running into some challenges in terms of dealing with that because she can't exercise much because she feels down all the time. She's constantly tired because of the lack of sleep. And she's actually flaring up from sweat and heat that she experiences during the exercise. Now, in terms of the family history, there are multiple first and second degree relatives with atopic dermatitis and other allergic disorders. With respect to social history, she is a former smoker, occasionally drinks alcohol, and has never used any drugs. With respect to the review of symptoms, not surprising, itch is highest on the list of really symptoms that are bothering her, but she also reports depressed mood and occasional wheeze related to her asthma. On physical exam, she has, perhaps not surprisingly, generalized xerosis or dry skin, and has these erythematous and hyperpigmented plaques that cover really 99% body surface area, as well as a number of hyperpigmented patches. But the key thing morphologically that was going on was that there was more of a follicular prominence that really covered most of the body, but certainly very heavy predilection for the trunk in particular. But she also had clear-cut flexural dermatitis with lichenification, eyelid dermatitis, cheilitis with that dryness and inflammation of the lips, as well as some mild ichthyosis on the anterior shins, that more leathery, scaly skin that happens. And although the atopic dermatitis typically presents in early childhood and remits at some point prior to puberty, as illustrated by Claire's case, it can persist into adulthood, and in many patients, even present de novo during adulthood. Claire's experience illustrates the impact of atopic dermatitis on an adult patient's life. She had the sleep disturbances, the interference with work, the embarrassment, the sense of social isolation, the depression, anxiety, and other mental health symptoms that happen, and sexual dysfunction as well. Now, in terms of the diagnosis of atopic dermatitis, we don't have any single test or biopsy that can be done to make the diagnosis. It is a clinical diagnosis made based on a constellation of historical features, morphology and distribution of the lesions, and associated clinical signs that can be supportive of the diagnosis. Now, it's important to understand some of the essential features that happen with atopic dermatitis. So, the concept of an eczematous lesion is actually a very heterogeneous lesion. We typically break it up into the classification of acute, subacute, and chronic lesions. And the key thing we look for is not just that morphology, but there are specific distributions of the lesions and age-specific patterns that we expect to see. So classically, as we see reported in the literature, predilection for the face and neck in early infancy, extensor involvement in late infancy and early toddler years. But the pathognomonic distribution that we expect, perhaps at all ages, but certainly in the older children and in adults, would be that flexural distribution of lesions, the antecubital fossa, the popliteal fossa, wrists, ankles, etc. And another aspect of this is not something like poison ivy where it's a single episode. It has that chronic or relapsing history that supports that this is really a chronic inflammatory skin disease. Very important and absolutely required in order to be confident and to make that diagnosis is pruritus or itch. Simply put, if it doesn't itch, it's not atopic dermatitis. It doesn't mean it has to itch all the time, but there certainly must be the presence of pruritus at least at some point in the course of the disease. Now, while everyone always thinks about itch when it comes to atopic dermatitis, we should also be thinking about pain, because even though it's not part of the criteria, it is something that plays a major role in the symptom burden of patients with atopic dermatitis. Recent studies conducted by myself and others have suggested that skin pain is both very common in patients with atopic dermatitis, but also quite burdensome. And so I recommend that skin pain severity be assessed along with itch severity at every encounter with patients, and really is an important endpoint for monitoring treatment response for all levels of severity. Now, getting back to the diagnosis of atopic dermatitis, there are a number of other important features that should be considered. So first, the early age of onset. That is one of those major criterion that we look for. Doesn't always have to be there, but early age of onset is certainly very supportive of that diagnosis, and that was something we observed in Claire's case. Atopic disease is also very important, as experienced in Claire's case as well. And what we mean by that is a personal and/or family history of atopic dermatitis, asthma, allergic rhinitis, or other type 1 allergies. This can also be demonstrated by the IgE serum levels or positive skin prick testing looking for allergens and immediate hypersensitivity reactions. Another one that is not absolutely essential but highly supportive would be having that background xerosis or dry skin. This was something that was a very prominent feature in Claire's case. And it's important to recognize that xerosis can fluctuate, much like the other symptoms and signs of atopic dermatitis. And there are some times of year that are much more prone to xerosis. There are a number of associated features with atopic dermatitis to be aware of with respect to physical exam. So atypical vascular responses. This would include facial pallor or white dermatographism or a delayed blanch response. In the case of white dermatographism, they actually rub their skin, and at baseline it may be erythematous and inflamed, and actually you get this blanching response where it turns white. And you can see an example in this image of someone with white dermatographism on the face who has atopic dermatitis. Keratosis pilaris, pityriasis alba, hyperlinear palms, ichthyosis are really part of a constellation of dry skin that often happens in atopic dermatitis. Patients can have any or all of those signs, and sometimes they can still have atopic dermatitis without any of those signs. In Claire's case, she had the ichthyosis present. She did report having more of the pityriasis alba in childhood, but hasn't had any of that recently. There can also be ocular periorbital changes or eyelid dermatitis, as we saw in Claire's case. Sometimes that's related to the atopic dermatitis per se. Sometimes that's related to the underlying or overlapping allergic conjunctivitis. Other regional findings would include perioral changes and periauricular changes. In Claire's case, she had cheilitis as well. Now, there are a number of other morphologies that can appear in patients with atopic dermatitis, like lichenification, prurigo nodules. These are lesions that are the more chronic lesions. They're secondary to either rubbing or picking the skin, respectively. There's another morphologic variant, which is the perifollicular accentuation. It can really happen in all skin types, but particularly more common in skin of color. Now, getting back into some of the different subsets of lesions, we talked about the acute, subacute, and chronic lesions. So let's focus in on the acute eczematous lesions. Acute eczematous lesions typically will manifest grossly as, pardon the term, but juicy erythematous papules and plaques, and may display even pseudovesicles or even frank vesicles with oozing and weeping. The lesions can possess crust and scales as well. Histologically, what you see when you biopsy acute eczematous lesions is really that characteristic spongiotic dermatitis or spongiosis with the fluid in between those keratinocytes and a perivascular dermal lymphocytic infiltrate. And typically you'll also see a number of eosinophils within those histological slides as well. When we think about chronic eczematous lesions, not only are they visually different, but there's also key differences on histology as well. So the key thing to recognize is that these chronic lesions tend to be the response of cumulative rubbing or scratching or picking of the skin. The longer they progress, the more they're manipulated, the more likely they are to progress to that morphologic variant. And what they end up appearing as is more of these very rough, thickened, hypertrophic plaques with the prominent accentuation of skin markings, which is the hallmark of lichenification. And histologically, what we see with more chronic eczematous lesions is we certainly will see the spongiosis, we'll certainly see that perivascular lymphocytic infiltrate with the eosinophils, but we also will see much more of acanthosis and hyperkeratosis, which represents that scaliness on the skin. It's important to recognize some of the morphological variants in different patient subsets. Here's an example of follicular eczema on the back. And when you look at this at first, one may actually not realize that this is part of the atopic dermatitis. And admittedly, it can be challenging at times. This needs to be distinguished from inflammatory keratosis pilaris. It also needs to be distinguished from follicular mycosis fungoides or follicular cutaneous T-cell lymphoma. Now, these are some images of atopic dermatitis in fair-skinned individuals. And you can see that really there's a range and a spectrum of presentations. Here's an example of someone with milder lesions in the antecubital fossa. And what you can appreciate is a very subtle pinkness. You almost might miss that if you're not really taking a concerted effort to examine the patient closely. They're milder, but they're there, and the patient is clearly quite itchy in these areas. You can also appreciate some of that accentuation of the skin markings. Here's an example of someone with more severe lesions in the popliteal fossa. And here you can appreciate really that angry, inflamed, redness, the excoriations, the accentuation of the skin lines, those ill-demarcated lesions in the popliteal fossae. And when you see this is really classic for atopic dermatitis. But in fact, it doesn't always have to look exactly like that. Here's an example of someone with atopic dermatitis that's sort of diffusely spread out throughout the back. And you can appreciate the erythema, you can appreciate a little bit of excoriations and edema papulation, but it doesn't necessarily have that same lichenified appearance or those same clear-cut flexural distribution. Now, there certainly can be challenges in terms of making the diagnosis of atopic dermatitis in patients with darker skin types. And Claire's experience really highlights these challenges in making those diagnoses. Many of the primary care doctors and even the specialists and dermatologists that she saw who weren't experienced in examining skin of color thought that the itch was all in her head. Here are some examples of atopic dermatitis affecting a middle-aged man with skin of color. And what you see is these lesions, they're not quite bright red as some of the other images that I showed you. They don't have that super inflamed look. They're almost purple in color, almost violaceous. If we would see this type of color in someone with a lighter skin type, we would be thinking more of a lichenoid distribution. But in fact, this is just atopic dermatitis in skin of color. Here's an example of someone with a prurigo nodule. We see this variant a lot, that in many patients with skin of color, sometimes we have a hard time appreciating the primary lesions and the primary erythema, but what we see is a very, very prominent role for prurigo nodules and really this response to manipulation of the skin. So when focusing in on some of those particular features and some of those challenges in diagnosing atopic dermatitis in skin of color, erythema is really the sign that most clinicians will try to look for and will really be able to focus in on in the physical exam. And if you're in someone with lighter skin types, it usually just jumps out at you, and it's kind of easy to see when the skin is very inflamed. Certainly you need to have appropriate lighting in order to be able to do that. But as you get into darker and darker skin types, it gets progressively harder to appreciate the erythema because of this concept of pigment masking, where the natural underlying pigment can actually block your ability to appreciate that erythema. Now, lichenification is another one that's very important when thinking about the assessment of atopic dermatitis and skin of color, because in darker skin patients, the skin that has become thickened often will look darker as well than the surrounding skin. And so sometimes it doesn't jump out at you, and it can be difficult to appreciate that accentuation of the skin lines. There are a few key concepts you can think about related to the severity of atopic dermatitis. So, recognizing that, what does clear skin mean to a patient with atopic dermatitis and in the clinical trial settings? Clear, typically, the way we define that is really no evidence of active inflammatory lesions. The dryness can be there all day and all night in some patients, even when they're not itchy and they have no other active symptoms, but the xerosis sometimes is always there. This is particularly a problem when, sort of in the dry seasons. And, we would expect with mild disease, you'll have some dry skin, but mild itch, maybe just a teeny bit of redness, not anything too prominent. For more moderate disease, the dryness may or may not be there, but now you're talking about much more frequent itching, more frequent or more prominent redness or erythema with excoriations. You'll already start to see some of that lichenification, or maybe even some of those prurigo nodules. And then when you get to the severe disease, now you're talking about much more widespread lesions, perhaps generalized xerosis, incessant itching, much more prominent and severe erythema. There's going to be excoriations with bleeding and oozing and crusting, etc. As well. And when you think about it from the patient-reported side of things, in terms of their impact on quality of life, mild disease, we would expect to have relatively mild or minimal impact on everyday activities. Not so much of an effect on sleep, not so much of an effect on psychological or psychosocial well-being. When you get to more severe disease, you're going to start to see really severe limitations on activities of daily living, much more of an impact on psychosocial functioning, and a much more prominent loss of sleep in patients secondary to that profound itch. So once we established that Claire had atopic dermatitis, the next question is, well, how should she be treated? The current treatment algorithm for atopic dermatitis really involves a stepwise approach, and really all the guidelines are consistent in that sense. All patients should be educated on the appropriate skincare approaches, ranging from the mildest of the mild patients all the way to the most severe. So I advise Claire to use non-soap cleansers while bathing and to apply ointments liberally, both moisturizing ointments as well as medicated ointments. the data have shown us that ointments are far more effective and overall better tolerated than creams. However, a lot of patients find them to be gross and messy and hard to use during the daytime because they can get on clothing and really slow them down in terms of when they're getting out in the morning. So I recommend application of ointments, particularly at nighttime alone. So I told Claire that moisturizers and medications are most effective when applied right after bathing. I also recommended that she take a plain water bath twice a week in order to really wash away a lot of the crud on the skin, maybe wash away some of the staph. It'll also help that concept of prehydration as well. I personally don't recommend bleach baths much because based on a recent systematic review and meta-analysis that we performed, they really don't appear to be any more effective than plain water baths in of themselves. And I've had some patients who've had some adverse effects from the bleach per se. And so I recommend just the plain water baths, and typically patients do quite well. I counsel Claire on the avoidance of irritants and triggers, such as stress, excessive dryness, heat, sweat, exposure to certain clothings like wool or other things that may be uncomfortable for her. But the reality is, as you get into the more severe cases, you're going to end up having to prescribe some kind of anti-inflammatory agent. I prescribed for her a mid-potency topical steroid. In this case, it was triamcinolone 0.1% ointment. And we gave her a 1 pound jar of it because given the extensive body surface area that was involved, a 30-gram tube wasn't going to do anything for her. If she was using the appropriate amount, it would have been done in a day or less. Additional considerations for Claire's treatment plan. We took an integrated multidisciplinary approach to care. That's part of our practice setting, but it's something that really adds a lot of value to patients and is suggested for atopic dermatitis patients who present with these other comorbid conditions, and the idea of really treating the whole patient. Now, Claire was already being treated for her allergies, her asthma, hypertension by different providers, but I was particularly concerned about her depression and recommended that she also see a mental health professional. So, what happened in her disease course? Well, overall, she did well for the first couple of months with this plan. Actually, within a couple of weeks, even though the disease was incredibly severe to begin with, the lesions melted away with topical steroids. But the challenge, as often happens with topical steroids, is even when you get short-term gains, long-term, they're just not enough to maintain, and you can't keep patients on it every day forever because of the risk of the side effects. So we tried using the proactive application of topical steroids to prevent flares 2 to 3 times a week, but it just wasn't enough. And she eventually just kept flaring up and really getting right back to where she was to begin with. And then when she started using the steroids again on a more regular daily basis, they just weren't working as well. So we had to figure out what to do next. And, according to the hot off the press atopic dermatitis yardstick publication, the next option would be to really increase the topical steroid dose or potency, or to consider adding a topical calcineurin inhibitor, or even to add something like Crisaborole. Crisaborole is a new topical option. It's a topical phosphodiesterase E4 inhibitor that was approved in late 2016 for mild to moderate atopic dermatitis in both children and adults. Compared with vehicle and clinical trials, it had been shown to increase the proportion of patients with clear, almost clear skin with at least a 2-grade improvement. It also showed improvement in terms of itch when compared with vehicle, and also showed improvements with respect to quality of life. In terms of the signs of the disease, improvements of excoriation, erythema, the exudation, lichenification, and induration papulation. And as I mentioned, perhaps the most important take-home message is that it really improved the quality of life in patients of all age groups. In terms of the side effect profile, overall pretty clean. The most notable side effect was application site pain or stinging, and the majority of treatment-emergent adverse events were considered to be mild or moderate and really not related to therapy. There were really no reports of long-term cutaneous adverse reactions in the longer-term studies, and so overall quite a favorable safety profile. But Crisaborole is really approved for more mild to moderate disease. Claire's case was just some of the most severe disease you're going to find, and so she really wasn't a great candidate for this treatment. But after discussing the various treatment options with Claire, and really thinking about the whole spectrum of systemic options or step-up options, what comes after topical steroid failures. It was clear she was frustrated with having to apply all the moisturizers and the topical steroids multiple times a day. It wasn't working for her, and she was covered head to toe with atopic dermatitis. So I discussed other options with her, and some of the other options included phototherapy, and a bunch of oral immunosuppressants such as cyclosporin, methotrexate, mycophenolate, azathioprine, or even oral steroids. I am generally not a fan of oral steroids, and it was something that Claire had already had exposure to oral steroids in the past and had gained a tremendous amount of weight related to that. Now, phototherapy, while a reasonable option, would not have really been feasible because of her job and the need to take off time from work. She was already struggling due to the lack of sleep, having to take up more time coming in 2 to 3 times a week on a regular basis, on a fairly inflexible schedule, but it just wasn't an option for her. When thinking about which of the oral agents we could use, because she had hypertension, cyclosporin really wasn't a great option. Methotrexate was also not a great option because of the risk of fatty liver disease and with her obesity and the hepatotoxicity associated with this drug. And actually, in Claire's case, she already had the beginning signs of non-alcoholic steatohepatitis, so it really wasn't a good option for her. In general, Claire seemed concerned about the risk of side effects with the immunosuppressants, understandably so, especially since she would be very likely taking them long-term, and that we needed to come up with a long-term treatment approach. I was happy to be able to tell Claire that there was another option. And in this case, it was enrollment in a clinical trial for, at the time, a new drug called Dupilumab. I explained to her about the mechanism of Dupilumab, that it inhibits the signaling of the cytokines interleukins 4 and 13, which are now thought to be the major players in the pathogenesis of atopic dermatitis. Now our approved dosing is every other week, but during the trial setting at the time, actually she was going to receive a weekly injection. She seemed willing to try this new treatment because she so desperately wanted something that would work and would be safe and well tolerated long term. So we enrolled her in the clinical trial for Dupilumab. And I have to tell you, it was an incredibly profound response. Within 48 hours, she was itch-free. For the first time in years. She actually called us up and said she hadn't slept like that in something like 20 years. The lesions, they took months to clear. It wasn't something that just happened overnight, but she was ecstatic because of the improvements of her itch. And that was the major problem for her, was the itch. Claire's experience mirrors that experience that other patients have had with Dupilumab and the efficacy of the agent. Dupilumab has been investigated in over a dozen studies overall, from phase 1 all the way through to phase 3, but there were 4 phase 3 studies that were done in more than 1,500 patients, and it has been studied both as monotherapy and in combination with topical corticosteroids and or calcineurin inhibitors. Really all of the studies have actually studied this in patients with an inadequate response to topical steroids, but there was one study in particular, the CAFE study, which examined the response to Dupilumab in patients who either failed or were intolerant to cyclosporin, clearly a very refractory population. So across all these studies, there are fairly consistent results. Dupilumab led to significant increases in the number of patients achieving a 75% improvement of the Eczema Area and Severity Index, as well as the number of patients achieving an investigator's global assessment score of clear or almost clear with a 2-grade improvement. It also led to significant improvements in itch, patient-oriented eczema measure, quality of life, significant improvements in terms of symptoms of anxiety and depression. Dupilumab was approved by the FDA in March of 2017 for the treatment of moderate to severe atopic dermatitis in adults whose disease is inadequately controlled with topical therapy or where those therapies are contraindicated. It can be used with or without topical prescription therapies, and in the new atopic dermatitis yardstick, it is recommended as a first-line option along with both phototherapy and immunosuppressants in patients who are not responding to topical prescription therapy. Now, honestly, if cost wasn't an issue, I think Dupilumab arguably should be the first-line systemic agent in most patients with chronic, moderate to severe atopic dermatitis. It is arguably the most studied medication in all of atopic dermatitis and has demonstrated more safety and efficacy than pretty much any other systemic medication out there. But you have to keep in mind that, Claire's case, fortunately for her, was an exceptional response. But in fact, there's a range of responses. Like any other medication, some patients may take a little longer for their itch to improve, while others can have more of that instant response. Some will have a complete clearance of itch, while others may have a 75% reduction of itch. Now, there are a number of other emerging treatments for atopic dermatitis. It's actually a very exciting time in the field right now. We have a very rich pipeline of agents that are out there. There are a number of different ones that have now presented with some positive phase 2 data, including therapies targeting just that cytokine IL-13 alone without the IL-4, targeting interleukin-31, which is thought to be that itch cytokine, and oral or topical therapies that are targeting the Janus kinase pathways. So the treatment landscape will likely continue to evolve, and we're quite excited about that. So let's get back to Claire. How's she doing now? Well, her lesions have cleared. She gets a spot here or there, but her body surface area consistently remains below 5%. If she gets a flare, they're much more manageable. She's still sleeping great, and as a result is doing better at work. In terms of side effects, she experienced some of that conjunctivitis. It's fairly mild for her, but that is one of the more common side effects that we see with Dupilumab. Her asthma's improved. Her mood improved. She was, feeling more energetic. She was able to go out with her friends more. She's now able to be more physically active. She's able to exercise now because, now the heat and sweat don't flare up her eczema anymore. And because of that, she's been able to lose weight, get her hypertension better controlled. Overall, she's a very happy camper, much better spirits, almost like a different person. And, we're ecstatic. I'm ecstatic. She's ecstatic that we really found a treatment that has worked so well for her. So, in conclusion, atopic dermatitis significantly affects the lives of patients, and it can also impact adults profoundly. But it's important to recognize that there are some key differences between children and adults, both in the morphology, differential diagnosis, and even in terms of its burden. There are a number of factors that must be kept in mind when diagnosing the disease, including the challenges in assessing it in skin of color. The treatment landscape is evolving and will likely continue to change with new therapies that can improve the lives of our patients. Thank you very much for listening to my story about Claire. I hope that you have found it interesting and can use what you have learned when managing your own patients.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/APZ. This educational activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals.